Is anybody here a pathologist? After Right. And actually, every time we ask medical students, hardly anybody knows who a pathologist is. And apparently, only thing they know about pathology is, what is that TV program? Yes. And that looks very glamorous. And I can assure you, my life is not like that. We don't do any postmortems. Christine at least looks at scans. All I do is look under a microscope. So I will just to let you know, because GISTs are so rare, sarcomas are rare, GISTs are so rare, I just want to let you know, for a pathologist, I will get on to why we play a role. For us to be allowed, so we spend 5 years at med school if you don't fail, then you spend another 7 years training to be a pathologist, then if people like, if you're crazy enough like me, you do a PhD, and by the time you start being a consultant, you're really old. And then we actually, any speciality we do, twice a year nationally, we get slides. And we actually have to do an external quality assessment. And you got to be not an outlier to be able to report these very rare conditions. Because as you know, you can't afford to get it wrong because that would be a total disaster. So in addition to having all those criteria and governance, because sarcomas are so rare, David and I, who are the two sarcoma, so in other words, we are certified, anything a sarcoma before treatment has to be seen by one of us. It has to go to the MDT. But just because it's so rare, we sometimes think we don't see enough. The two of us actually, we liaise, we have a scheme with the Marsden or the Christie, so that, because we know the pathologists, we have a slide sharing scheme as well. So just to let you know, and I think we are very, very quick. If we are not sure, we would send it to an expert, even if it's across the pond. Because I think getting that thing right is what we are supposed to do. But obviously, because we are so, I've been termed autistic, we are actually the pain of all the surgeons or the oncologists' life, because when they phone me and say, can you tell me what it is now? I'm like, no, I'm sorry, I can't. You'll have to wait. So I'll get on to, so GIST and EGIST. Everybody was talking about GIST, that is gastrointestinal stromal tumors. I put in EGIST just to complete. You can have extra-intestinal GISTs as well, right? So it's about what is a GIST, epidemiology, micro differential diagnosis, how it behaves, and treatment options. So luckily, I'm handling only the things in red because all the others have been done by Robin and Christine. There was a plan to why I was doing last because most of my talk is already done. So, so it's very common. It's in the gastrointestinal stromal tumor, it is the most common mesenchymal tumor. It's not a cancer, but it arises from the specific tissue. So in the GIST, in the gastrointestinal tract, and it is from the intestinal cells of Cajal. So I won't do anything of this except to say, previously, the surgeons just looked at a scan or they said everything in the stomach or in the intestine was a leiomyoma. It just means it's arising from smooth muscle. And believe me, till a few years ago, there was still some calling it that. And to the extent it drove the two of us, David and I, so crazy. We said, we are organizing an education day. And they were made to come to say, don't label this. Don't tell a patient a random name without looking at the pathology report. So it's actually first described in 1983. And in 1984, the two groups named these GIST. And it was only in 1998 that they actually discovered the driver mutation. So it's actually something not very old. So that it happens anywhere, and that's what Christine said, but actually EGIST, that's the extra-intestinal GIST, can occur in the mesentery, retroperitoneum, or even pelvis. And they think it is during development, certain cells have dropped off, and lost its connection to the intestinal system. And that is how it might be giving rise to it. So I won't go through the symptoms because it's already been done. But just to emphasize that most of the time, I'm sorry, I don't know, none of, who you are or what you presented with, but sometimes it is very non-specific because it just could be due to the not a big bleed, but constant small bleeds. We have patients who come with anemia or abdominal fullness, nothing very specific. And that is why I would love, we're actually running some education programs with GPs and things like that, because what you're saying is, if a person comes to you and is coughing up blood, that is one thing. But even things like this, there is something happening. So if it usually single, and if it is multifocal, in addition to meds, what we are really worried is, are these inherited GIS? And Jane is there, so I won't talk much because I'm sure Jane can tell a lot more than I. So the diagnosis is basically dependent on integrating the histology, on the scans, but the biopsy, and we do immunohistochemistry and molecular analysis. And I will sort of go a bit more onto that. In addition, I think the pathology is an inherent part of the risk assessment, because I think, as mentioned, it is the site, the size of the tumor, and the mitotic count. So these are just straight off the internet. It's not something that I've taken off from STH patients. So that's the type of on the endoscope. And you can imagine, if any of you've had this, that is a type of, it's obviously magnified, the endoscopy. And this is the cutting edge, right? So what I want to just emphasize is, Christine sees these enormous masses, and I am sent what is taken up by that piece. So if I get anything more than 3 millimeters, that's really good. Yes, she does give me nice big biopsies. And I think other thing to emphasize to your GP, or if somebody, you have that, somebody thinks there's a mass, and they do an endoscopy, because GIS very rarely involve the top layer of the intestinal tract. I'll show you a picture. When they take the biopsy, it actually might miss the tumor, right? So it doesn't mean that if there's a query of GIST, a normal biopsy is actually everything is clear. So I think that is why I don't know whether you have access to our reports. We try not to be too rude about the surgeon, but we do say, that if it's a query GIST and if it's normal mucosa, we put a statement in there saying this could be perilesional tissue. So in other words, very politely, go back and take a better piece. So sometimes, even if the endoscopy is not possible, they actually can do a transduodenal, across. They can stick a needle and suck up tissue. And that's what we call a fine needle aspiration. It's a very fine needle, and sort of, because of the capillary action, you can take pieces of tissue. It's the bane of our life because these are even less than 2 millimeters. They're tiny, tiny specks. And we actually have very well-defined and very strict protocols in the lab in how to process these, because we just don't want any tissue to be wasted. So in other words, how many times they spin it in a tube, and how they sort of, what is put in, and how many levels they can, because all these tissue are spun down, they're poured into wax, and then somebody actually sits down and cuts it at 4 mu thin sections, 4 micrometers, right? So we don't want to waste tissue at all. And that's the type of example that I might get. For example, so this is a really good piece of tissue, which measured 9 millimeters. And for example, the photograph is magnified 200 times, right? So, and that is actually the normal gut, and that is the tumor. So in other words, so when we get this biopsy, we know there's tumor tissue, and then to analyze it further, what is this tumor? Because as Christine mentioned, when you got a diagnosis of GIST, that is known. But actually, at that biopsy is to ask, is it GIST or the 20 other mimics or other types of tumors in the stomach or the intestine? So every time a biopsy is taken, it is discussed at the MDT room. And actually, there's quite a lot of controversy at the moment in the NHS, how useful MDTs are. But actually, it is very useful because it gets together a group of people who will see something very rare all the time. And like any profession, if you see something constantly, I think whether you like it or not, you get better at it. You learn more. You learn from your colleagues. So that even if, for example, I would know that Robin would want me to do mutational testing. So if there's not enough tissue, I roughly know which pathways I do, rather than just go through the same routine all the time. So that is what we do in sort of, it is quite a dark room, and there is sometimes disagreements, but we are supposed to say we are a happy family, but we are actually. Like the sarcoma MDT is lovely. And then this is an example of what has been removed. So unlike those little FNAs or co-biopsies, sometimes the surgeons think this is small enough to remove. And then what we do is we actually get all these specimens fresh into our lab, so that in other words, it comes without putting any fixative. But the problem is, even though it's removed from the patient, these cells are dying, because it's lost its blood supply. So what we have to do is we sort of slice into it as soon as possible. And if we are doing any, we say research studies, you might sample a piece where you need fresh tissue. And then we sort of pour in formalin, which is what actually stops the cells dividing any further. In other words, the cells don't die. So we let it fix very well. And then maybe 2 days later, we might go in, and obviously I can't sample this entire thing. There are very strict sort of criteria as to, depending on the size, what we sample, how many blocks we take, and then we get the slides to look at. And that's the type of example of a slide we might have, and this is under very low magnification. And that's the normal intestine, and you can see under that there is this lobulated tumor. And there's a small lymph node just next to it. So I agree that I do spend my time looking at pink and blue. In fact, once I had brought my children into work on a weekend. Well, anyway, I can own up, they're quite old now, so I can't be charged for child abuse. But I asked them, and I said, oh, do you want to see what I do? And they said, oh, you got such a boring job. You have only 2 colors, just. So the microscopy is, for example, these are the type of specimens we might get. Now, these are 2, again, co-biopsies, right? You might think they look similar, and they do look similar. These are what we call very spindled cells. But this is a GIST, and this is a smooth muscle tumor. You manage them totally differently. You stage them totally differently, right? So that is the type of differential diagnosis that we go through when we see a small spindle cell tumor. And I'll be very happy to go on for hours, but even at the MDT, I'm told to, yeah, that's okay, now get on to the next case, because I'm boring. And then, so these are the, those are the spindle cells. Sorry about that. These are the ones where they are more spindled, and where carcinoma is always a problem. So we do have some sort of things we can do, because all these cells, like the clothes we wear, every single cell has its own unique print, like proteins on the surface. And we can sometimes, we microwave these, we use acid, and we sort of upregulate these proteins, and we can put another dye which actually sticks to that. So therefore, a carcinoma would have a different set of markers as opposed to a GIST. So that is what we call immunohistochemistry, and I'm sure all of you have heard this CD117. And that is, CD is cluster differentiation. It's just an international nomenclature for every type of antibody we are using. So CD117, which is also called KIT, and that's what we do. And that is because 95% of GIS are very strongly positive for CD117. It's a very specific and sensitive marker, and that helps us to differentiate. And the only problem is the intensity of staining is no indication on whether it's a KIT mutated tumor. So that is only for diagnosis. And a negative KIT on immunohistochemistry does not exclude that the patient's tumor will respond to a tyrosine kinase inhibitor such as Gleevec or sunitinib. So it is just something we use to separate GIS from a very small sample from its mimics. And we also have something called DOG1, and that was actually because it was discovered on GIS. I always tell is pathologists are really boring. You know, the names are exactly what it means. The MDT, I mean, we are having another SAG meeting, you know, sarcoma advisory group meeting next week. And there are some very rare tumors called, you know, with a specific mutation called CIC-DUX. So my MDT lead has actually termed my talk as pathology pets, because apparently we have dogs, we have KIT, which is for cat, sick ducks, you know, anyway, they always laugh at me. So we do DOG1 and KIT and CD117 as very specifically to confirm that it is actually a GIST. Because I think because you all have such, the tumors are so unique and its response to specific treatments are so unique, it is not worth getting it wrong. You know what I mean? It's just two antibodies. It's not worth getting it wrong. So this is what I told my kids. I don't only look at pink and blue, I also look at brown, because all our immunohistochemistry is tagged brown. So all these are GIS, and you can see how varied they look. They're all mutation-proven GIS, right? But they all stain with these two antibodies, so they are proven GIS. That's just, again, different tumors. And that's just to show you we don't do only a KIT and a DOG1, because what happens is a biopsy is taken, the patient is incredibly anxious to know what the outcome is. So we can't do only those two, and if it is negative, to get on to the others. So we actually, every single biopsy, we might do this entire panel of immunohistochemistry. So that is CD117, DOG1, Desmin, SMH, Caldesmon, anyway. So it's a lot of acronyms and numbers. But that shows with the sort of combinations that they express, it sort of gives the ability to make a diagnosis with much greater certainty. Because none of these are 1 equals 1, you know, it's not like that. It's just the combinations and how they appear in panels. So that is why the pathology is not, we sent the biopsy to yesterday, what's the diagnosis today, right? And then in addition to that is the risk stratification which you've seen. So this is the Mitanin and Lasota classification. You can see depending on whether it is the site and the size of the tumor, the third one is how many mitoses. So not only, so I spent quite a lot of time under the 50 high power, sort of we look at the high power magnification, that is you scan it at 400 times magnified, and we count in 50 high power fields. So you look at 50 fields on the microscope and you count how many mitoses are there, right? So if it is between the borderline of 5, because you can see they have chosen that number, we would ask the other pathologists to do it as well, just to make sure that nobody is missing anything. So it just shows why I spend a lot of time in the lab. Then the thing is, then we send this tissue for mutational analysis. And I think that is why we have a protocol as to how we handle these biopsies, because we can't finish them. The tissue biopsy, which is, you know, like a 3 by 1 millimeter piece of tissue, by cutting into it, doing immunostains, because tissue has to be preserved for mutational analysis. And as Robin said, there's a very small percentage of GIS which are hereditary. KIT mutated GIS are about 85 to 90%, and the PDGFR alpha mutated GIS 5 to 8%. And these two mutations are mutually exclusive. You don't have a given tumor with both. It's either driven by this mutation or the other. And actually what happens is, it's just not the whole gene. We are looking at very specific areas of the gene. And I know Ian had done an extensive talk. Was it last time you all had the meeting, Jane, about mutations? So I'm not going to go to a great deal.
Many of the patients here won't necessarily have been in London, so.
All right, okay. I love a chance to talk about pathology, but I will stop soon. So what we do is, you have to be very specific. In that gene, you look at, in a given genetic code, you have the exons, and the introns are the ones that are not actually coding for something actively. And each of those ones that are coding are given a number. So we look at actually 4 areas of the KIT mutation, and the D816V point mutation on 17 that Robin was talking about for the trial is one of the specific points that are specifically looked for. So in other words, so in addition to the 4 exons of KIT mutation, PDGFR alpha also has 3 specific hotspots that are looked for. So in other words, for a lab to be able to offer a mutational service for GIS, the basic requirement is that they have to look at all 7 spots in every single sample, okay? Because we just don't want to miss anything. So that is why there are very strict criteria as to which labs can do this testing, and we are very happy with the service we get from Birmingham. So that is for PDGFR alpha. So they would do all the KIT mutations, all the PDGFR mutations, and if they are negative, you might think, okay, did the pathologist get that answer wrong? But I think as all those posters show, you got the other tumors, GIS tumors, which do not have the two common genetic things. So we do look for BRAF gene mutations, and we look for KRAS as well. So that is done as a second tier. So always, all of them get the KIT and PDGFR. If it's negative, get on to BRAF and KRAS mutations as well. And that is important because BRAF mutations predict primary resistance to imatinib in GIS. And they also have other mutations like any other tumor. But these are not driver mutations, so they're not checked for all the time. So in addition to these mutations, you could be totally mutation negative, and you still got that very small group, and that's the PAUSE one, and that's the pediatric group, which could account for about 1 to 2%. And I think that's really important because these are extremely rare in children. And I think that is why one of the few good things coming from NHS England is that to diagnose sarcomas or to manage sarcomas, they have to be managed in a center that sees at least 100 new a year. So we are trying very hard to get pediatric pathologists. It's not because they're not good, it's just that because they see such a wide range of cancers. I'm very lucky. I do only 2 types of cancer, so I can concentrate all my learning onto that. So what they're trying to say is they always have to be countersigned by a sarcoma pathologist. Then of course, once you get pediatric GIS, we start looking for other things like paragangliomas, because you have the Carney triads, the Carney-Stakakis syndromes, and I think we've had 1 or 2 of these patients, because these are actually hereditary GIS syndromes. And I think it is very important to give the patient and the family the option of being able to screen their other members. And then though pediatric GIS express KIT protein, the majority lack KIT or PDGFR mutations, so they are the ones that need to be checked. There are other wild-type GIS, which are termed wild-type, so you get it in neurofibromatosis. and you also have familial GIST. And as I think what was shown you ad nauseum, what happens is, as Robin said, this is, you need something stimulating this receptor, but when there's a mutation, it starts stimulating on its own. So that's the driver. So that's why we do mutation analysis, and on this side it is just to show you, depending on the mutation, whether it is exon 9, exon 11, 12 of the PDGFR, it just shows you whether it's sensitive or resistant to the drugs. So that is directly linked. And so the prognostic factors are what you've been shown before. So there's a revised NIH risk system, there's a GIST nomogram, and that is it. So I'm just going to show you an example of one of our patients who had the tumor. I won't dare to guess what it is or where it is with Christine around, but because she's hiding there, that's the one. And so that is the specimen we got. And what was unusual when we cut into it is that you see multiple lobules. And that is not what we see normally in a standard GIST. And what was the other unusual thing was one of the lymph nodes in the surrounding mesentery had GIST going into it. And as we said, GIST very, very, very rarely go into lymph nodes. So this is somebody. So we did prove it was a GIST. So you can see the c-KIT and the dog one is expressed in every cell. It is indeed a GIST. We did the mutations, the PDGFR and the KIT, they were negative. So we thought the lobularity and the negative, you start staining for things like succinate dehydrogenase B. And this is a negative stain for that, and we shouldn't have that. But the same tumor stains for succinate dehydrogenase A. So actually, this is one of those succinate dehydrogenase deficient GIST, one of the tumors that do not respond to the TKI treatment. So just to show you why the pathology is done for a GIST. Okay, thank you.